talk about awake and opioid-free fusion surgery using a new block. Thank you. This is my disclosure. This is where I work. So, well, you all know pain is bad, so we have to do something for pain. And the problem is that we use usually opioids to control pain. And we have a problem with that, especially in the US. There's a pandemic, and you know that an epidemic of opioid prescription, and spine surgeons are the ones to blame for, in part for it, but we are the ones that prescribe opioids for the longest time, so almost 13 days, okay? So there's two ways to control pain. First is the type of surgery, the other one is the type of anesthesia that you use. So in the type of surgery, you know that MIS is the way to go. And it's very important also to get the patients moving quickly, okay? So actually early ambulation matters. You want to get your patients on the feet as quickly as possible, especially if they are older ones. So you all heard about endoscopic or percutaneous TLIF using the transcamin approach. Basically, you use a Camin's triangle to place in a cage. This is a very old or initial prototype that we had. We started, actually my father reported in 2010 the placement of the first TLIF cage. As far as we know, this was the first one that was ever placed. And yeah, this is a typical percutaneous TLIF. You see in the wounds where you have the small incision for the cage. And well, we've been publishing about this technique for a long time. And we have developed now a new dilator that allows us to place big cages, large footprint interbody cages. So basically, you use the usual approach to the disc, and then you slide in this new dilator. This dilator allows you to get into the disc, and it has two stages, as you can see here. So once you are inside the disc, you take out the dilator stage, and what you leave in is a nerve shield. And this nerve shield protects the exiting nerve root. And as it is not open, as it is not a tube, it's not tubular, it doesn't have a diameter, it's open, you are free to use any kind of cage and any kind of instrumentation to place it. Okay, so we use reamers, manual reamers, to progressively ream out the SAP. So we use this nerve shield, as you can see it here, and we place the reamer over it. And this allows us to slowly take out the SAP millimeter by millimeter, up to 30 millimeters of diameter. So you can see here, we do this all using only fluoroscopic imaging, no need for endoscopy. So this means that you are very, very quick, okay? And so bit by bit, millimeter by millimeter, you take out the SAP. If you are in need, for whatever reason, to use the endoscope, you can place the endoscope, you can use the burr, and you can take even more of the SAP, okay? As you can see here, I took out almost everything of the SAP, and you can get a very extensive foraminoplasty. But this is optional, you don't have to do it. Then you can use open instrumentation. So this is a regular curette that you get in an open TLIF set. You can use rongeurs just to do a quick discectomy, because with endoscopic instruments it takes forever, okay? And this is for the same patient. This was the disc preparation that I got with this system, and this was in a higher level, a cranial level, and you can see that you got this was a lateral approach, and you can see that you can get a good disc preparation with this transcambin fusion set. And once the disc preparation is done, you can use it to place a cage. This is a huge cage. I have 3 talks later today during the day, and I will present the cage. It's not about the cage, really. It's about how can you place such a big cage inside the disc. And the whole point is that we don't have a tube. You don't need a tube. It's just half the tube, and so it's open, and you can use any cage. It could be this cage, it could be any other cage. It doesn't really matter. So we use, again, only fluoroscopic imaging. And then you have your cage placed inside the disc. Okay, this is actually how it looked like. So you only have the fluoroscope to guide you. And once it's inside, you can expand the cage. You can see here huge cage expansion, and that's it. Okay. So this is just at 1-year follow-up. Some examples you can see, because this cage, what I like about it is you have this huge graft window. Okay, so you can place a lot of graft inside. So this is 1-year CAT control scans. You can see the fusion there. So it's working pretty well, the discectomy and the cage placement. So that was the first part. very truly minimal invasive surgery, small skin incision, no dissection, and this is by itself a very good pain control mechanism. But there was something missing when I was operating patients like that. Yes, I could put them on their feet quickly. Yes, I could discharge them within 24 hours, but they still were in pain. Especially the first time you wanted to get them out of bed, they were feeling it. Okay, so I was looking for a long time for a way to get this pain out of the patients. And I found many years ago at the NAS a presentation by Dr. Sharan, who will be talking later, okay, of a protocol that allows me to do that. And all the other protocols that I was seeing, all these ERAS protocols, they were very complicated, okay? Multimodal pain management, pre and postoperative conditioning of the patient, many disciplines involved, psychologists, anesthesiologists, pain doctors, etc. That was not feasible for my private practice, okay? This was not something useful for me. And what Dr. Sharan actually introduced me to, by chance, because I just happened to attend an industry symposium, was an ultrasound-guided thoracolumbar interfascial plane block. So what is this? You use a needle to get between the multifidus and the longissimus muscle, and with the ultrasound, you place your needle exactly at the plane between both muscles. And by doing that, you will get your local anesthesia. It will dissolve around the whole muscle group. It's like a highway for your muscles, okay? And this allows you to get a huge area of local anesthesia. It's not just the place where your needle is, it's really, truly almost the whole low back, okay? And this is a video, very quick video. It's actually very easy to do. This is a spinous process. This is the needle going inside, and this is the plane between the multifidus and longissimus muscle, okay? So once you're in there, and you will see now the description, the anatomic description of the different planes, okay? This is the plane, this is the needle, this is the spinous process, okay? So once that you are in there, and you see it was very quickly, now you inject the local anesthetic. You see how it opens up? So you're seeing now how the two planes are opening up because you're injecting the local anesthesia. Okay, so you can do. Once you have this, it's easy that you do awake TLIF surgery, okay? Because you have a huge area of anesthesia, the patient won't be feeling it. And actually, my anesthetist tells me that after doing this, he's doing a very mild anesthesia. He calls it the baby anesthesia. So you don't have to go so deep because the patient is not in pain. So we did this study, single-level percutaneous TLIF cases, single center, multiple surgeons, prospective study. And we had two groups, the one group with using the TLIF block, one using the standard opioid analgesia, neuromonitoring for all patients, okay? This is the general anesthesia protocol, and after surgery, all patients got the same analgesia, but they had a manually triggered pump. So whoever was in pain, they could push on a button, and we would register when they were using the morphine, okay? So this is the demographics, and you see, well, there's no significant difference between any of the two groups. And our results, if we take group by group, TLIF group, significant differences at hospital discharge between preoperative and postoperative scores. But the non-TLIF group, despite getting opioids, you know, only the VIS-LEC scores had significant differences. And we compare both groups preoperatively, no differences, but postoperatively, you can see that the TLIF group had better VIS leg and VIS back scores, okay? So if you took a look at the scale, you can see the significant difference here only at hospital discharge, of course, because the effect is always temporary, right? But you get a significant difference. So the TLIF group, despite getting opioids, they were using the pump all the time. They had worse results than the TLIF group, and not one single patient used the opioid group. And I'm finishing right now. We published this not a long time ago. Just quick cases, 56-year-old female, quite fat, and she had a history of painkiller abuse. She came to me because she knew she was going to be in pain, but she could not take any opioids after surgery. Spondylolisthesis, got a single level TLIF. Okay, you can see here the incisions. She got the TLIF block, and this is her 6 hours after surgery. Okay, no opioid medication, no tramadol, only paracetamol. And look at her face. She's smiling. Okay, she's out of pain. It even impressed myself, okay? She didn't even take an ibuprofen during the whole postoperative process. So this is the postoperative control. At 2 years, she's doing really fine. Fusion at 1 year, fantastic. And second case, truck driver, big man, strong man, 2-level fusion. I placed both cages using only one incision, okay? At 1 year, 0.05 ODI, and this is again video just a few hours after surgery. He's walking better than I do, okay? Also, no pain, just ibuprofen, no tramadol. So, again, postoperative control, CAT scan. So in conclusion, the strategy, if you combine a truly minimal invasive surgery, which is very important, like percutaneous TLIF, in any ways that you know, with a block, a TLIF block, you will get an excellent pain control that will also allow you to do the surgery awake. You can do it with general anesthesia, but your patients will not need opioid in most cases, opioids, tramadol, whatever it is, in the postoperative control. Of course, it just only lasts for a few days, but it's enough to get them moving, and then they get the confidence, and they won't need the pain medication anymore. That's it. Thank you very much.